Go.
Well, good morning, everybody. Welcome to this joint webinar, which is being hosted by Think Low Clap Personal and the Association of Mental Health Providers. Just to let you know that we will be recording this session and you'll be able to pick up the webinar in about 2 hours' time. You'll get a message about that. I'd like to introduce you to the panelists that we've got this morning. Isaac, would you like to say hello to everybody?
Morning, everybody. My name's Isaac Samuels. I have a lived experience of long-term mental health challenges, and I'm a member of the National Co-Production Advisory Group.
And Rachel, would you like to say hello?
Excuse me, sorry. Morning, everybody. My name's Rachel Peacock. I'm CEO at Making Space, and I'm also a trustee of the Association for Mental Health Providers.
Marsha?
I'm Marsha McAdam. I'm a member of the NCAD Group National Co-Production Advisory Group. I have a lived condition of borderline personality disorder and some physical health problems.
Thanks, Marsha. And Duncan?
Good morning, everyone. My name's Duncan Tree. I work with the Association of Mental Health Providers, and I've been working with Martin, Marsha, Isaac, and Rachel on the arrangements for this session today.
Thanks, Duncan. And I'm Martin Walker. I'm a policy advisor at Think Low Clap Personal. So today's webinar is about effective care planning for people with mental health challenges. You'll be, during COVID, you'll be able to submit questions and comments using the questions box. That should be the facility. That facility should be available to you. We'll pick those up. Please do submit questions as we're going along, because once we get to the question and answer bit, you know, we'll need to move straight into that piece. Just to let you know, we're not going to have a break this morning. We are doing a webinar which is a little bit longer than normal for us here at Think Low Clap Personal. So if you do need a break, just pop off, get yourself coffee or nip to the loo. That's entirely fine. So without further ado, I think I've covered everything there. Questions, use the questions box, break and recording. So we'll move into a little bit of context setting, if that's okay. So this webinar came about in discussions with Duncan, between Duncan and myself initially. And Duncan was telling us about the work he was doing with the Taskforce. Duncan, could you tell us a little bit about that?
Yes, so thanks, Martin. So I think the background to the event really is the extent to which the pandemic has confirmed the really critical role of social care and adult social care in meeting the needs of people with mental health challenges, keeping them safe and preventing future mental health issues, and also in the promotion and the maintenance of people's mental health, independent living for people with mental health challenges, and the wider well-being of local populations. And it's not widely recognised or perhaps acknowledged, but it's local authorities, it's councils through their Care Act duties, who are the primary local commissioners and public funders of voluntary and community sector and independent sector providers of mental health and well-being services. So I guess that's the sort of operational service and I guess sort of practice context for the discussion today. It is only just over a year ago that Think Low Clap Personal Partnership and the Association worked together with the National Development Team for Inclusion to produce a resource called Making Personalisation Real for Mental Health. And I guess the value of that resource and the value of the narrative contained in that document has been sort of seen throughout the pandemic, certainly since, you know, over the last sort of 4 or 5, 6 months. In the summer, the association was asked, along with the Association of Directors of Adult Social Services, to lead an advisory group that was that explored the role of adult social care in meeting the needs of people with mental health challenges through the pandemic. We led that advisory group to report into the Department of Health and Social Care's Social Care Taskforce. We held 3 hearings. There was a strong emphasis on personalisation, lived experience, and the need to consider inequalities within the remit of that group. But what really became clear was how critical personalised social care was in looking after and in making sure that people with mental health challenges were in the first instance kept safe, but also exploring how they could best participate and continue to live as best life possible within their local communities. So today's session, I think, is an opportunity to consider and explore some of those issues further in the context, I guess, of the critical role as I sort of highlighted, of councils in commissioning, planning and delivering support for people with mental health challenges, and to understand and amplify how critical personalisation is in that context, and to recognise that we may need to adjust and I guess consider what more needs to be done to make sure that we don't lose sight of personalisation as we continue to live in a society where the pandemic looks like it may be with us for some time. So over to you, Martin.
Great, thanks for Duncan. Thanks for helpfully setting the context for the discussion. Importantly, both at Think Local Act Personal and I know many members of the association, co-production is at the heart of the work we do, and working with people with lived experience of care and support. And so, first of all, we thought it was very important to hear some of that lived experience. And Marsha and Isaac have introduced themselves. So first, we're going to hear from Marsha. Marsha, welcome today. Would you like to tell people about your experience of care and support planning, effective care and support planning during this period?
Thank you. So if I fast forward, or I rewind to
Sure.
about 2-3 years ago, some of you know that I got really ill because I'd had breakdown with 4 different domiciliary care agencies over a short period of time, and I actually ended up in Crisis Point, which is a 10-day stay place, because I really didn't want to live anymore because of the continual breakdown. And I went through one stage where I had no care at all. And I remember it taking from December and then April time, then I finally got some care. And the care that I got, I've had for 18 months, and it was just supposed to be temporarily. And a few weeks ago, I found out that even though I knew that I was going to be passed on to another agency and that, we basically got told on a Saturday that the carers, it was an in-house care team, which is the best of everything. I call them my fairy godmothers. They really are. I mean, I've had one of them today. She's called Chicken Soup Jane because she makes the most amazing soup and that. But she's like straightened my hair and made sure that my clothes are ironed and I've got my lipstick on. And she stuck, her head through the door, just sort of. And then tomorrow she'll want to know what this is about and everything. And I couldn't have got through the last few months if it hadn't been for Chicken Soup Jane and Holistic Jane, and I really could not have got it through at all. And what happened was they were put in temporarily while my community mental health nurse and the City Council worked together to try and get a domiciliary agency that address both my physical and my mental health needs. Whereas the reason that it'd been breaking down before was because it was just people coming in for my personal care, and unfortunately having to leave earlier to get onto the other job. They've also sometimes I didn't know who was coming through the door at 8 o'clock in the morning, and that was at 7:30 at night the previous night. And I used to be a bit of a recluse, but now that being involved in the stuff that I am, I suddenly have a bit of a social life and a bit of a determination. I'm able to really contribute things, and so the in-house care was so good because they really encouraged me, you know, to do that, and they were flexible with some hours. I was able to speak to one of the managers there on a weekly basis, and she'd send me who was coming the week, you know, ahead, and I would know that they would come through the door at 9 o'clock until 10, and then 6:30 until 7:30 at night, all the time, and that just was amazing. Because I then started feeling confident, and I mentioned earlier about the diagnosis of borderline personality disorder. A lot of it can be emotional distress and persistent distress. So for me, it was really important to have something secure in my house. And so to find out a few weeks ago that was being cancelled, firstly, I was devastated because I was thinking about Chicken Soup Jane and the others. And then I was sort of thinking, oh, the other thing, the reason that they were waiting was so that there could be a toilet put in downstairs. Because when I'm in-house, I'm upstairs all the time. Because sometimes with the fibromyalgia and that, you like really use a lot of energy just doing even basic things. So instead of using the commode downstairs and being embarrassed and all that, so they'd arranged for the city council to come and put a toilet in downstairs, but then COVID happened and it all stopped quite a bit. But then to then find out 2 weeks ago that the care was moving over to a package that we didn't even know if they would have mental health support or that. So, and I know I'm speaking to like managers and that, I understand that they're having to move from services due to the winter pressures, but I would really ask you to really think, yeah, you may be saving some pennies along the way, but what about me, and what about others like me who I've not been calling my CPN, I've not been kicking off for like 18 months and all that, I've not used Crisis Point. What about all those things? All that money saved. And so I remember Isaac and Martin and myself, we met with someone from ADAS. He's an amazing chair, and she wanted to know a bit more about, you know, the stuff that and why it was working, and it really does work. And so my call to you is please think about things like that. So yeah, sorry if I'm waffling, I'll stop now. But
that's fine.
But that's what's so important to me, and it is what has kept me sane over COVID. Yeah.
I'm sure that will have prompted lots of comments and questions. Thank you very much, Marsha, for sharing your story so openly. Thank you. We're going to hear from Isaac now. Isaac, over to you.
So good morning, everybody. My name's Isaac. I live in the east of London. So at the beginning of COVID, my whole life just seemed to pause. I lost all of my family connection because I wasn't able to see any of my family or my informal support network because I'm in the shielding group. the only person that I was able to continue to see was my PA. So if there was ever an argument around personalisation, the argument has been won. My PA has been able to offer me support in a way that has meant that I've not only been able to stay safe, that I've been able to continue to do stuff that makes every day worth living. I have had no mental health crisis, and we've really identified some of the stressors. So I had lost all of my natural support, lost all of my medical interventions, no contact from the community mental health team, really challenging times. What do? You rely on. And for me, it was something that was really born of social care. So personalised care planning was and has meant such a difference. Getting through COVID has been so much easier because actually when all of the staff have been redeployed at the local authority and someone called me, I could signpost them to my personalised care plan that has all of the context that's important to me, all of the people that needed to know. But the really important thing to recognise is that this work was done because of personalisation and because of social care. And health has disappeared because obviously we can't access health because we're in that extremely critical group. All of our connections have disappeared. The only thing that's in place for us is social care. So the preparation was really key. So the preparation has been 20 years worth of conversations about what's important to me, what's important to my support network, how do I manage in the worst possible scenario. And I never actually thought that anything like this would ever happen. This is a complete nightmare for people with mental health challenges because nobody's known what to do. I've been really fortunate from those conversations. I had a risk assessment, and that telephone number, when I called that number, when I was having a bit of a wobble at 4 o'clock in the morning, not being able to get hold of my PA, had a bit of a wobble, called that number that was in that plan, and somebody said that they would call me back. They did. They signposted me to a local charity that's really enabled me to get through this. I've had one-to-one sessions every week of therapy, and I would really say that the voluntary sector has responded in really challenging times to people like me. The other thing that's been really interesting for years and years and years, I've been banging on personally around digitalization and the need to make things more accessible. All of a sudden, everything became really accessible. And there are some pros and cons. Some of the cons for me is making my home environment, which is my safe space, really unsafe at times. But it's about thinking about that. It's about planning. It's about recording those conversations and working in a person-centered way. So co-production is another example. I think we were challenged before COVID around co-production. In COVID, I've just seen a massive increase of people like myself being able to connect to ministers, being able to really shape the task force, being able to connect locally around co-production. The other thing that's really important is that when you think about personalised care and support planning, and you identify what's important to someone, days often change day to day. And within social care, they're able to, I felt they're able to manage that. So I had to self-direct my support. So it's been really flexible, it's been really person-centered. I've been able to say to my PA to do things that they wouldn't have historically done. There's been guidance that supported people to manage some of those challenging conversations that we might have with local authorities. The other thing is about recording that information. So we've been able to really record some of the changes, and there's been quite serious changes in terms of my health, because where I've not been able to access health, that's meant services, NHS services, that's had a massive impact on my social care. The thing that's been really, really great to see is that across different services, so I live on the border, so my GP's in one borough, my social care's in one borough, my mental health's in another borough, my consultants all over London and special hospitals, and it's been really good to be able to say to people, actually, before we have the call, could you please just read my one-page summary? And that's really given people the right information. It's meant that I've been able to not only manage some of the challenges, and medication in COVID has been a big challenge, but it's meant that I've actually been able to email people, have conversations, mitigate some of the challenges that have occurred because of the lack of provision. I would like to say that it was unique to COVID that people were struggling to get services. That isn't true at all. I think some people's experience of mental health services is they may see someone every 3 months. My experience was very different. I would see someone every month, and it would be a big stressor to spend half a day travelling to a building that was a Victorian building, that would have acutely unwell people in that space, that inevitably the consultant was always late because they were dealing with someone really ill. And I would leave there feeling absolutely distressed and suicidal. I don't have to do that anymore. I can have a phone call with my consultant that's 10 minutes and it's about how I'm doing, what's important to me. I think we've got some great opportunities to learn for some of the lessons of COVID. It's been a mixed approach, and there's been good and bad, or areas for growth. And but you know, I would just say that social care for me has meant that I'm sitting here today having this conversation because I've been able to stay safe, continue to do the things that I love, but also really plan for what next. And you know, we are looking at a potential really challenging next 3 to 4 months, particularly people like me with lots of health and social care challenges. And being able to pre-plan and get those people involved in those conversations at an early stage is only been possible because of personalised care and support planning. So if we ever needed an argument for doing it in a co-produced way, the argument has been made, and that's COVID. The other thing I'd like to just highlight is the workforce. The workforce have been working in really challenging times and have been doing their best. Some my community mental health team were redeployed and other people came in. And the difference having a plan has made is that those people have been able to view that information and really engage and not spend all of that time on the phone with me, missing the point. So that's me, Isaac, and I really do think that we really need to be working in a more person-centered way. And the backbone to person-centered approaches for me is care planning.
Thanks ever so much, Isaac, again for such a personal and very connected story to today's webinar. Thank you very much. We're now going to hear from Rachel. Keep reminding you, sending your questions. I can see 1 or 2 are coming in. But we're going to hear from Rachel Peacock from Making Space, one of the association's providers of care and support, about your organisation's approach in this period. Over to you, Rachel.
Thanks, Martin. Just let me get my headphones working. There you go. Morning, everybody. Thanks to Isaac and Marsha really for setting the scene around what social care does really. Social care is about helping people have a life with meaning and purpose. I think when Marsha talks about being connected to some of the networks she is, that's what makes a difference to us all as human beings really. And just a powerful statement that Isaac talks about every day, having a day where every day feels like it's worth living. It's just, that's really what social care is about, whether we are accessing social care or whether or not we are delivering social care. So Making Space is a national charity. If I could just ask for the next slide, please, Sanjay, so we can just explain what I'm going to do today. What I always like to do when I talk about the work that we do at Making Space is I like to consider the 3 pairs of shoes that are involved in social care, particularly for those of us who work at or access services in Making Space. So the 3 pairs of shoes for me are the people that we support in lots of different types of services, but also it's really important that family or significant carers are considered in this. So in our DNA, our organisation, family members and significant carers, so important to us. And I think both Isaac and Marsha have talked very clearly today about the workforce. Without a social care workforce, there's no social care as well. And if ever there was a time to demonstrate how important the social care workforce is, it has been through this pandemic. So everything I talk about, I'm considering those three pair of shoes as we go ahead. So could I have the next slide, please? So just really briefly about Making Space. We're a national charity. We've been operating for just under 40 years now. We started in 1982. We employ 1,000 employees across England mainly. We can operate in Wales, but we mainly work in England. On any given day in Making Space, there are 450 people volunteering for us. And of those 450 people, 150 of those people are people who are accessing our services. So they might be volunteering in the service that they are accessing, or we have helped them to volunteer in their local community. We did a bit of a tally of how many people we've possibly supported since 1982, and we come to a very sort of underestimated number of 200,000 people. If you think back to the 1980s, we didn't collect data the way we do today, but we're fairly sure we've supported over 200,000 people in the 38 years we've been operating. So a lot of experience and always learning. So could I have the next slide, please, Sanchi? What's really important when we think about services, if I just very briefly explain, Making Space delivers services in the local community, but we also deliver residential services, and we have 2 independent hospitals. So, and we support over 700 people in supported living services as well. But every service we deliver, it's the person who comes into that service, their life and their needs that shape our service. So this is Jonathan. Jonathan lives with us in Sherdley Court. Sherdley Court's a residential care home in the St Helens area of Merseyside. It's a beautiful purpose-built home. It's only a very small home, 16 beds. But when Jonathan was assessed to come and live in the care home, he was really actually quite anxious. He'd lived independently really well in his local community for many years. The main thing he was really worried about was whether or not he was worried about having to rehome his animals. So you can see there Jonathan's cat, Jacqueline. He didn't want Jacqueline to have to be rehomed, so Jacqueline come to live in Sherdley Court as well. And when I was double checking my information with our registered manager at Sherdley Court yesterday, Hayley also reminded me, Jonathan also brought his mouse as well. So Hercules has come to live in the care home too. So we've got our cat and our mouse. Hercules apparently lives in his cage. He's quite happy to be fed and watered, living in his cage. But Jacqueline's now a member of the Sherdley Court family. So he's got a whole host of new friends and family to look after. But mainly Jonathan's happy, because Jonathan's got one of his most treasured, can we just go back to Jonathan for 1 second, Sanchi? He's got one of his most treasured treasures there. But also in Sherdley Court, they really love their chickens. So we have 6 chickens living at the service as well, because the residents wanted fresh eggs every day. So every day we collect fresh eggs, and Craig, who's our chef, and the residents in the home make a plan about what they're going to make. I love going there because usually the plans are around some beautiful pastries, cakes, all my favourite things, all the things that aren't good for you, but they make us happy. So that's Jonathan and Sherdley Court. So if we could have the next slide now, please. Thank you. So I think Isaac and Marsha have both talked about the importance of personalisation, and I just can't emphasise enough how much a one-page profile, a really well put together one-page profile, can really help, and has helped even more so during this period. So this is my one-page profile. We do one-page profiles for the people we support at Making Space, but the staff are all working on theirs as well. There's so much that you can get from a one-page profile really quickly. In the what's important to me section, it gives you some hooks in terms of things you can find to talk to people about. You'll often find things that you have common interests in, or if you're not a Liverpool supporter, you might want to just give me a bit of stick, and that's fine as well. I found put in the section around what people like and admire me about. I found that really, really difficult. And most people I talk to say the same thing. It's really hard to place yourself in the shoes of somebody else and view yourself through the lens they view you through. So that bit took me quite some time. Can we just pop back to that one slide? Thanks, Angie. The most important part of any personal profile really is how you can be best supported. So because this is a personal profile for me in my workplace, we've made this about how you can best support me in work. One of the most important things I recognised when people talk to me about what impact I have on them was I'm quite an extrovert. I'm always talking, I think out loud, but when I'm worried about something or I'm trying to work out a bit of a problem, I actually go really quiet and I start tidying up. So if you want someone to come around to your house when you need a bit of tidying up, get me when I've got a bit of a problem to solve, because I go into big organisational mode. But what people around me told me was they get really worried when I go quiet. So actually just having that out there in your personal profile, what behaviours you present yourself with when you're worried or when you're thinking about something, it really, really helps. So if you haven't got personal profiles in your services or for your workforce, whatever your workforce shapes like, I would really, really advise you to go ahead and put one together and put a lot of time and effort into them, because they're so powerful. Thanks, Angie. Can we move on now? So just briefly talking about some of the people we've supported during COVID-19, and as I've said, we have lots of different settings. So this is Bob, and Bob lives in one of our independent hospitals. We have 2 independent hospitals at Making Space. One of them is for people who have a diagnosis of dementia, and what's really important in that independent hospital is having a holistic health and risk assessment. So it covers all of the type of things that both Isaac and Marsha have talked about. It talks about some of your mental health issues, but it also looks at any kinds of physical conditions that you've got as well. So recognising the parity between your mental health and your physical well-being. So people with chronic conditions, the effect on their mental health can have a huge effect on their everyday living. We've also looked really closely at really tailored activities. In our independent hospital for people with dementia, music is a huge connector for people, but we've also adapted the environment, so there's lots of murals. When I was able to visit one of our homes recently, I went in because the residents had invited me over to show me what they'd been doing with the place while they'd been locked down during the spring, and what they'd been doing with the place was they'd painted murals all over the building, Tom and Jerry, so there seems to be a cat and mouse theme going on in some of our Making Space services, but the kitchen's now been decorated into a Tom and Jerry kind of theme, and I was really pleased because they had put a bit of an LFC mural up. I think that they've done that just for my benefit, and it probably went the day after, but people in that residential home decorated their homes to their tastes and what they want. It's just beautiful to see. So that's Bob in our residential unit. Can we move on, please, Sanchi? We do also support people with learning disabilities, and one of the things that's really important, again, both Marsha and Isaac have talked about this, it's either family or carers, but it's co-producing those services. So this is Sheila, and what was really important for Sheila, this is Sheila, the picture of Sheila, she's at one of our events. We have a huge event every year for the people we support. This was over in Blackpool Tower Ballroom, where we kind of took over the ballroom for the day. But what's really important in terms of co-producing Sheila's support plan is the information about her strengths, what she can do, not what she can't do, but what she can do, but also picking up some of those fears and what we can do to help reduce anxiety for Sheila. So spotting what the signs are for her anxiety, and also what will help her feel safe and secure in the service that she's in. So that's Sheila. Can we move on to the next slide, please, Sanchi? Okay, and here's Fred. So Fred in our independent hospital, again, remember people with dementia, a lot of what's really important to them is reminiscing, and it's how people are made to feel. They may not remember that the family member have been to visit them, but they will remember how they were made to feel when that person who actually is familiar to them came to see them. So we do a lot of work around life storybooks. notebooks and memory boxes, because reminiscence is so important. But that's important for any of us, whatever, wherever we're at in life. Just being able to draw upon those good memories is really important. Again, one-page profiles, I just can't emphasize enough. But what's been tough for us all during this process has been having to close our care homes and only allowing essential visitors to go into the care homes. So we've stayed connected with family members and significant carers by producing lots of carer magazines and holding lots of carers groups on social media, so we can actually keep people in touch. It's not ideal, there's no replacement at all for human connection as far as I'm concerned, but we've got to make the best of what we've got. And I do think, as Isaac did say earlier on, it actually has accelerated social care in terms of using digital platforms a bit better, because we're not great at it, and it's definitely an area for us to improve. But that's really important for us, particularly in our care homes where people can't visit at this point in time. So could I just have the next slide, please, Sanchi? I do want to emphasise workforce. So the social care workforce don't get enough attention. So one of the things that we found happening for us very early on during the pandemic was staff teams contacting us and letting us know all of the amazing and wonderful things that they were doing to respond, really. And what we decided to do was to have a bit of a celebration of that, and we called the celebration our Windmills and Walls campaign. And that comes from an old proverb which says that when the wind is blowing a gale, some people will build windmills and some people will build walls. So we're a bunch of windmill builders here at Making Space, and these are just a few images of some of the windmills we built. So the picture that I'm looking at on to my left is of Teresa. She's got a beautiful, beautiful smile, and she's wearing a purple top. And there's a young woman next to her called Demi Lee. Demi Lee's at the local sixth form college, and they've set up a pen pal scheme. Teresa is one of those residents who just human touch is really important to Teresa. So a hug and a smile and a bit of a story about her wild days when she was younger is always what you're greeted with when you go to see Teresa. So she's been sharing her stories with Demi Lee, and they featured in Chat magazine a couple of weeks ago. So she's so delighted. Her daughters are delighted as well. But that connection would never have happened if it hadn't been for the fact that we had to close the service to visitors coming along, and we wanted to widen up some of the community connections. So that's Teresa and Demi Lee. In the picture where there's a car boot full of food packages, this is in our Manchester Supported Living Services. We worked with the local Myriad Foundation in Bury, and it was really important that some of the very basic needs were being met for the people we support. In supported living schemes, a lot of the people we support became very anxious about going out and just getting their shopping and things like that. So actually just delivering some food packages to people just so that they've got something nutritious to eat made a huge difference. But we did that with another local charity, so it was brilliant. And then the last two pictures at the bottom of my screen are in some extra care services in Darlington. So actually getting residents onto computers and using their computers, really, really important. But the picture of the young woman in the tunic, Sophie, and the lady holding the card, what they decided to do in Darlington was just invite all the local school children to send a card to all of the residents, and the residents were delighted. They couldn't believe we were inundated with cards, and they just couldn't believe that the local school children had taken the time to write to them. So beautiful. And what our support worker said to me was, I've given up concentrating on the things I can't do, and I'm just going to focus on the really good things that I can do. Absolutely brilliant. So that was our Windmills Not Walls campaign. Very proud of that. And just very, very briefly, I just want to talk about our workforce. We have a small practice development unit at Making Space, small but perfectly formed, and they've done a lot to support our workforce in online sessions, really working hard on reflective practice, because it's been hard, that it's been tough on the workforce, and they've been tired, and they've been going to work when they've been worried about themselves and their family members as well. And we've not had any problems with getting our people into work and supporting people. We've had more problems asking people to stay at home and rest, if I'm perfectly honest. But we work on a basis of autonomy in our teams, so it's really important to me to listen to the evidence base that tells you that if people have autonomy in their workplace, they will do a better job and they will care better. So we've had lots of action learning sets and lots of teams groups, and we've invited guest experts to come and talk to the staff, just to keep them motivated and feeling that they're being valued as well. And the last slide, very briefly, thank you. It was really important, whatever your workforce is, whether you are employing PAs or you're an organisation like Making Space and have a large workforce that's dispersed across geographical areas, it's really important to look after the staff. So the staff can't look after the people we support unless they're well themselves. So we did a bit of a survey about 3 months in. Out of our 1,000 staff, nearly 600 responded. So that's a good response for us. Told us some really good things we're doing well, but also told me where we can improve as well. So a very basic one, the last bullet point, we set up a text message service, and only 72% of the respondents told us they were finding it useful. Really, really simple stuff. Turned out we didn't have everybody's mobile phone number in our system, so we got hold of everybody's mobile numbers. But the most important one for me is the staff feel that their well-being is being supported. So we're looking at lots of different ways to do that. And as I say, whatever your workforce is, do think about how you support your staff during this period as well. That's everything from me. Thank you, everyone.
Thanks very much, Rachel, for that very enlightening presentation about Making Space. Real practical, good practice example we hope for you this morning. So I think we're now moving into time for questions. So please do keep those questions coming. We've had a few. Kirsten's got some questions for us, panel. So the first question. Oh, before I do, sorry, I shouldn't just jump straight into that. Marsha, you did just let me know you just missed something out of your story that you felt was important to just share with people. So sorry, before we just jump into the questions, Marsha, did you just want to just let people know what you wanted to say?
Yeah, I'm sorry. I've been a bit nervous because I'm living in the change that's happening at the minute, so I didn't want to appear I was being critical. I just wanted to point out that the reason that there'd been sort of I'd been under the in-house team for so long was because we'd had a mental health provider who was branching out to domiciliary care come and do an assessment, and they would be able to sort of wash my hair, but they weren't able to touch me there below. Or if the commode needed emptying, or if I needed cream for whatever reason so they then suggested that, oh, we can work with your emotional needs, get an agency in for the personal care. And it was like, no, I need all one thing. So then that was so then they went looking elsewhere and everything. But the main thing is that, so I've basically found out 2 weeks ago, that it's all going to be rushed through, and the service is supposed to be, it's going from like 2 teams to 1 team at the end of this month. So it's like they were trying to get me into another agency by the end of the month, but I'm like, luckily I've requested an advocate, a Care Act advocate, to make sure that my needs are addressed. But then people are trying to push it to go to panel and stuff like that before I've even been assessed for a Care Act. So this is why the reason I wanted to mention it is because it's really important, and being a member of NCAG and sort of knowing Isaac and Sally, and that is understanding a bit about my rights but being in the middle of it, it's quite a bit scary. But I wanted to say that the care team, the carers that I have are unbelievable, and if I could box them up in a perfect ribbon, I would do. But yeah, so sorry, I just didn't want to. Yeah,
it's no problem. Thank you very much, Marsha, for that addition. So let's get the questions. The questions are coming in now. First question, I think probably popped up as Isaac, you were talking. The question is, from Kirsten, are PAs only available to people over 18? So who wants to take that one? So Isaac.
No, so I know lots of families that have young family members, children that have PAs. So it's about how you access the identified support needs. And some people choose a direct payment or personal health budget, and then they will employ PAs.
Anybody else want to respond to that one? I think it's fairly straightforward. Just ask your commissioner in your area, in the practice team that you're working with should be able to help you with that. We know at TLAP though, arrangements can be patchy and variable across the country. So if it's not working in your area, or you can't find it in your area, we can help you connect with other organisations that can help you ask for that sort of thing and support you through that process. Next question. Well, I think we've got a couple of comments, but an interesting prompt just to see what people think. People I support, I think it was when you were talking about emergency response, Isaac, that people I support often only have a crisis plan of phone 999. What do you think about that? Rachel, I see you nodding there.
Well, yeah, that's not a plan, is it? Let's start there. That's not a plan. I think one of the things that got accelerated at the start of the pandemic was the need for all of the mental health NHS Foundation trusts to have a crisis line. So we were operating. We operate a lot in the Northwest. I connected with Northwest Boroughs because they set one up within 2 weeks. They'd had a year to set a crisis line up, but actually had to do it within 2 weeks. So it wasn't ideal. People we were supporting were contacting that to be told, you're already known to services, you shouldn't be phoning us. So we had to iron out a little bit with some of the advisors on there. But to be fair to Northwest Boroughs, they were really, really responsive in terms of how that service can improve. So 999 is not a plan. That's not a plan. I think it has to include significant numbers of local people that you know, and that you know there's going to be somebody at the end of the line as well. And that might actually be a significant family member or carer, could be a friend as well. But yeah, that's not a plan, but is what I'd say.
No. I mean, Duncan, is that a sort of experience that other members talk about in terms of sort of patchy approach?
Well, yeah, I think NHS England's aspirations around access to crisis support are very clear, and they should ultimately establish some consistency. But as Rachel says, it's variable. Referring someone to a 999 service is not a plan. Referring someone to a crisis service at which the end is an answer phone is not a service. But what we are hearing is that crisis services are very overstretched, that there has been an escalation in the severity of people's mental illness and the need for them to access services, but there's not the capacity in those services. And so what's happening is there's been a consequent increase in the need for police interventions. And of course, some of those police services in many areas will be well versed in supporting people with severe mental health challenges in times of crisis, but it's not ideal, of course. But it is an issue of capacity that I guess that predated COVID. But we're faced with a twin storm, really, aren't we? We've got an escalation in mental health crisis and needs as a result of the pandemic, and a capacity in both the voluntary and community sector and NHS services that was stretched beforehand. But back to Rachel's point, That's not a plan. And I think this is Isaac's point, ultimately, that actually a plan is something that matters to him. A plan is something that identifies the things that keep him well, and that should be reflected. And I think what was clear in some of the discussions that we had in the advisory group to the task force was the extent to which many people, even prior to the pandemic, with mental health challenges and looked after ostensibly by acute and community mental health trusts, didn't have a plan. And of course, everyone is entitled to have a plan. And I guess Marsha's point is relevant there about the importance of advocacy services in helping people to ensure that they have a plan.
Thanks, Duncan. We've got some very supportive comments in terms of Marsha and Isaac relaying your stories. I mean, is there anything else you wanted to say about crisis response, Isaac or Marsha?
So for me, it is a commissioning issue if you do not have a good crisis response. So it's not just having, so the worst possible outcomes you could ever imagine are those people with mental health challenges that go in via blue light services. They end up more likely to be sectioned, more likely to have extended stays, and don't receive the care that they need in sometimes 3, 6, 9 hours worth of conveying and finding a service. People lose their lives. There are many reports on that. So for me, it's having a wide range of options, and that will be, you know, where to contact during 9 to 5, what to do after the 9 to 5, voluntary sector. The really important thing is not to forget co-production in this, because we had a crisis line and they were not responsive. They were not at all able to respond to people's needs. And through co-production and through people that access the service being on part of that monitoring process, we now have a much more responsive, trauma-enforced practice crisis response line. It is mixed across the country. The Royal College of Psychiatry have done various guides around, you know, blue light guides, community, and all of those really do highlight the need for a multi-level plan that has a wide range of information, advice and support. And Marsha's point is really important, that often when it goes wrong, people need advocates to overcome those challenges. And it's often not the people that have the most need, it's often the people that shout the loudest that get the right support. And in COVID, it's been really apparent that lots of my peer support members are in hospital because they haven't had that responsive response from NHS services.
Thanks, Isaac. And Marsha.
I've got two things. Where we're talking about advocacy, so I referred to advocacy, but it was going back and forward, and now there's they got like a backlog, so that postpones things even more. And it will be those that shout the loudest almost as well. So there's that insecurity type thing. In my care plan, I have diabetes, but I also use food as a way of controlling the situation, which is something that during COVID I've really used. And the carers, because they know me, they know that a few weeks ago I stopped taking my medication for a few days, and it was just because it was the only thing that I could control. And it was those carers that came through the door, those 3 or 4 named carers that encouraged me to start eating again. They were pointing out to me that, hey, you're not actually drinking that much, you know. And it was, without them, it's just for the people on the call, there's so many different crisis is not sort of defined one way, is it? I may have a crisis that's completely different to other people. And what I'd like the people on the call to sort of think me is just stop being so boxed in, sort of think bigger, wider.
Yeah. Thanks, Marsha. That leads quite nicely to a couple of questions for Rachel. The first one's a fairly straightforward question. Does Making Space only operate in England? And the second question, Rachel, is it sounds like your services become more person-centred during COVID. I wonder if that's typical of other services in other places.
Okay, so yeah, we only operate in England. The organisation began in the northwest as part of when the large hospitals were closing down. We were kind of part of that plan in the northwest, but we operate. I always describe it as we operate services between Cumbria and Cambridge. That kind of, just because a bit of alliteration helps me really. It's we have about 80 different contracts across the country, so it's all contracted services through adult social care. In terms of becoming more person-centred during as a result of COVID, I think it's similar to some of the discussions we've had about our health services or other types of provision. It can be patchy across the country. So my point of reference really is my experience as a trustee of the Association for Mental Health Providers, and seeing some of the amazing work that some of our members have done. You know, there's some of the helpline services have really they were great anyway, but they've really stepped up. Places like Anxiety UK, they've really stepped up and filled a void that really statutory services have made. So they've come into their own, I would say. But I would also say that there are organisations who have struggled for staff. So trying to attract staff to social care has been a tough one for many years anyway. So you know, come and work to us during an international pandemic isn't really a recruitment line that you can push too often. But yeah, my experience really is the Association Mental Health Providers, they've really stepped up to the challenge. I worry that we're not all going to make it through to the other side. You know, the discussions around funding are really tough. We as an organisation, we're supporting lots of small local charities in the areas we work in to help them keep operating as well.
And Duncan, have you seen a move, more of your members their practice becoming more person-centred, or were they in that place generally? I mean, Rachel's obviously talking about their a good sharing across membership anyway. But what do you think about
that? Well, I think yes. I think many of them were in a place where, you know, I think, you know, Isaac will sort of validate this. I hope that actually that, you know, it's voluntary and community sector organisations that by and large led the journey to personalisation that started, what, 25, 30 years ago. You know, there have been some big milestones in that, for example, the Direct Payments Act 1996, I think. So many of them were on this journey already. I think that many of them will have seen it's the only way to provide, you know, a meaningful service to people and keep people safe is through personalisation. So it's a non-negotiable, I think, in arrangements designed to support people, you know, outside the context of a pandemic, and it's absolutely non-negotiable within the context of a pandemic for the reasons that Isaac set out. You know, Rachel, you know, rightly identifies the extent to which organisations like Anxiety UK have really, you know, put their, you know, had to sort of step on the accelerator to increase provision. And many organisations have also fast-tracked the provision of their services via remote and digital means. Now, you know, that's been really helpful and successful, I think, in many ways in keeping people safe, in providing a service that otherwise they wouldn't have been able to provide as a result of the physical distancing requirements. But we're only just beginning to learn about the long-term utility of services provided by digital means. It's not suitable for everyone. There's some misconceptions about whether or not, you know, it's people have a preference on the basis of where they sit in a demographic. So there are some assumptions that young people would prefer to have their services provided by digital means. Well, actually, lots of providers will tell you that they've got long waiting lists of young people 18 to 24 that don't want to have a remote contact, that don't want a video consultation. They prefer to wait and sit and need to see someone in a physical space by the nature of the fact that, you know, they don't want to see themselves on a screen. So I would say short answer to your question is yes, I think there's been an acceleration in the extent to which people have used a range of means to try and improve the provision of services, personalised social care and support services for people with mental health challenges in the sector. But back to Rachel's point, there are huge pressures on the workforce. So you know, at the early end of the summer, people are anticipating, or there was some messaging to the effect that things would be very different by Christmas, we'd be through this. That's clearly not the case. We're in a second wave. We're seeing associated mental health challenges, and the extent of those challenges, increase across the general population. And the reality is that social care services, their value and that they are perhaps less valued than NHS services when it comes to keeping people safe and well, certainly in terms of the extent to which staff are remunerated. And we also are in a place, I think, where the critical importance of care and support services, social care, in terms of mental health and well-being is less understood. I think generally social care is understood in being having a role largely in relation to older people in residential and nursing care. But clearly, what the pandemic has revealed, and what opportunities like this do, provide us with a wider lens on the critical role of social care in supporting people with mental health challenges. The challenge on that is actually to ensure that the sector is stable throughout the winter period, so it can keep people safe and well.
Thanks, Duncan. I know you want to pick up on this, Marsha. We've had a question come in just as part of that dialogue, I think. Does there need to be a new digital inclusion revolution and new learning? So do you want to say what you wanted to say about digital, Marsha, and then respond to that question?
So for me, we're going to conferences and workshops and that, and I love traveling to London all the time, from Manchester, and it was getting me away of these four walls. And then COVID happened, and it's all digital. And what it's actually made me realize is, and I don't know the right wording, but my cognitive skills are not that good. And when I've watched myself back on recordings and that, I sort of raised my eyes as I'm sort of talking, and I didn't realize that I do things like that. And it has really started affecting my confidence. So like Duncan, when you were saying about some of the young adults, they don't necessarily want that tech, do they? And as a 44-year-old woman who started having confidence in herself, it's now, so do I carry on engaging and stuff like that, where you sort of see all this, or it's, does that make sort of sense?
Yeah, it absolutely does, Marsha. Yeah, and there's lots of challenges with it and lots of things to think about, aren't there? Rachel, have you got any thoughts? And then Isaac, sorry.
I mean, I think yes, we do need to accelerate our use of digital. But I think the points Marsha makes are just so important, really. I think being able to be connected like this, there are webinars and things that I've attended during this time that I wouldn't have travelled to London for. I can't be in London at 9 o'clock in the morning travelling from Liverpool, because that's getting a train at 6 o'clock in the morning from where I live, and I don't like 6 o'clock in the morning. I like 6 o'clock in the evening. So for me, there are things I'd have missed out on, but equally I really miss that human connection. So whilst this is great, it's never going to replace that kind of interaction with humans. I think the point around young people accessing digital services, there are young people that I am really close with who have been accessing face-to-face counselling and have not wanted that to go digital, and have put it on hold and will wait until they can actually sit face-to-face with their counsellor, because fundamentally we're humans, and that's what humans do. We want to be connected with each other. So yes, it should be an enhancement and an improvement, Martin, but it can never replace it.
Yeah,
so we're doing some work, Martin, that Isaac's been involved with on the experience of digital access to mental health services during the pandemic. We're calling it a principles framework. It'll be published in November, but our starting point on this, of course, is that digital in the first instance has to be an enabler in the first instance, but we also need to recognise that it can be a barrier. So our bottom line is not digital by default. It's a means to accessing a service, and we need to recognise and understand that it may not be viable for everyone, and to address the barriers that exist for many people. And some of those barriers are basically as a result of people's social and economic circumstances. Affording the kit is one thing, but actually paying for an ongoing line and internet access is something else. So at the risk of repeating myself, it has to be an enabler, but we need to recognise it can also be a barrier.
Thanks, Duncan. And did you want to say more, Isaac, on this?
I think it's also really important to see it as a two-way street. So often we talk about digital for the end user or people with lived experience. We really do need to focus on the digital abilities of the workforce, because some of the challenges, actually, we assume that the workforce is digitally able. That's not the case in my experience. And when we talk about digital, are we really talking about digital, or are we talking about phone? It's having a mixed approach to meeting someone's needs is really important. Really thinking about the two-way nuances of digital is another one that's really important. And I think it is really interesting to see co-production has become probably really telling of digital, that actually a lot of people that were co-producing before COVID no longer co-produce. It's become a very white space. It's become a very those that have resource space. So I think it's a bit of a challenge, digital, because actually, people don't have the same connection to it. People don't see it as useful. The other thing that I would say from my personal perspective is that digital fatigue is really, really challenging. And the default position at the moment is everything should be digital, no consideration to what impact that has. The other thing that I think is quite interesting is when we look at digital solutions, there is nothing done around whose data is it, how do we consent to that data being used, what does it mean in terms of those interactions, and having a workforce that can really deliver digital interventions in a sensitive way can be really, really challenging. And I don't think we've done any of the ethics around what does it mean to have a digital offer.
Okay, so that's digital. We've talked about the benefits and difficulties of digital quite a bit there. We've got a question bringing us back to one-page profiles. We'll focus on one-page profiles. Quite a long question. Having a one-page profile to summarise a person's mental health needs, co-produced by the person, would be incredibly useful if then used by all agencies, including primary and acute or specialist care. What can be done to promote this idea nationally? Isaac wants to take that.
So one of the things that I love one-page profiles. Often people misunderstand that one-page profiles are not just for the person with lived experience, and actually it's for everyone involved in that person's life. So I think it works really well when actually you come together as someone that provides a service or an intervention with that person and both create a one-page profile. It should not just be the person with lived experience. It can be a lifesaver. My one-page profile tells you everything about me in a really summarized way. I think when you access a multitude of services, being able to share that experience across just gets really time consuming. It feels like you're always talking about the problem saturated areas rather than those good things. I love one-page profiles, and I think they really help that human-to-human connection.
Rachel, what can we do to promote it?
I think that the networks like the Association for Mental Health Providers could work with members. So I think the more of us that do it, the more people will come on board with them. Just same as Marsha and Isaac, I'm a huge fan of them. I'm a huge fan of them for the staff teams as well, because it helps you get the right connection for people. But I think really for me, if our national infrastructure bodies can help us, and TLAP as well, just showing the power of them. I'm a great lover of storytelling, so if you can tell the story around that and how it made a difference, so people can actually see what the worth of them are. And for busy people, even if it's just a basic kind of, this will really help you connect with somebody really quickly. Whichever way we can kind of shout out about them, that's I'm all for it. So yeah.
Thanks, Rachel. And just on that score, in terms of TLAP's contribution, I'm pretty sure, I'm sure somebody will be able to help me out in the back of the back office support, that the personalised care and support planning tool that is on TLAP's website and used extensively by the sector has got one-page profiles right at its heart as one of the key elements of good practice in this area. Pretty sure. So we'll get you a link to that as part of the information that we provide later with the webinar. Anybody else want to say anything on that? Okay. So we've got another question around, does the panel think that community mental health teams and crisis services will learn from the initial lockdown and provide a more tailored and responsive service as we move to more restrictions again? So we're kind of coming back to crisis, but have we learned from the first phase? Are we gonna change our responses time? Do you think? So it's one or two smiles there. Duncan, what do you think?
Yeah, it's a shame that we haven't got anyone representing community mental health teams or the NHS on the panel. But I think it goes back to the discussion really that we're having around one-page profiles, and in the first instance, people having a right to a care plan. And I think we need to be really, really clear that everyone who's assessed in being in need of care and support in an NHS or social care services has a care plan in the first instance, and that a one-page profile that's, I guess that's been, like organisations, charities like Rachel have produced on co-produced with their people that use their services, might be a good show and tell way of looking at what improvements can be made. So the value of one-page profiles, I guess, and the value of good care planning during the pandemic, I think, and showing that to NHS commissioning colleagues and indeed colleagues in social care about what good looks like would be helpful. I mean, there are many organisations in the association's membership who will tell you that they have been producing care plans with people in the absence of a care plan from the NHS or statutory services. Now, on one level, that speaks to some shortcomings in statutory services, but it also points to the value of the sector and what you can do through co-production. So I can't remember exactly what the question was. I'm not sure whether I answered it entirely, but yeah, I would hope that CMHTs will see the value.
Yeah, whether we'd learn from phase one.
I would hope that CMHTs will see the value of live personalised care planning. So what COVID has really shone a light on why they are essential, not just in terms of safety and well-being, but in terms of living a life that people with mental health challenges are entitled to lead.
Thanks, Duncan. Anybody else on that one? Isaac.
So I think personalised care and support plans are fundamental to people having the right support in a very systemised approach to providing care and support. I think what we possibly will learn is that investing in bricks and mortar and a centralised approach to supporting those with mental health challenges hasn't worked in COVID. So bringing lots of people into one space to see a psychiatrist or care coordinator hasn't worked. Those places that have had much more of a community-facing service, where they've been able to work closely with individuals in a person-centred way, where they've really had good co-production, where they've really had a good understanding of personalised approaches and care plans, recovery care plans are the backbone of their service, have done so much better than some other areas. So one would hope they would learn. I think going forward there will be a period of reflection, and do we need to offer local provision in the way that we've traditionally done it? I don't think so. I think we will have to have a very different approach because of the group of people we're talking about. But what I am sure of, we'll never ever be able to offer any support that's meaningful without a personalised care plan, and that approach really does have to be holistic and across multiple systems, because like me and Marsha, we access health, social care, mental health, and the only thing that seems to sit across all of those is the care plan, not the people, not the conversations, not the system.
Yeah, I mean, it's a really good point, actually, and it throws something back to the system. Do we really need an integrated bureaucracy and commissioning set of arrangements if people have got a single care plan that provides the context in which services can be arranged around? So if we start with a person, if we start with a care plan, I think that raises all sorts of questions about the desirability or indeed the necessity of integrating bureaucracies. I guess the other point is back to Isaac and indeed Rachel's and Marsha's point about actually understanding the critical role of voluntary and community sector providers, not just as providers, but actually crucial sources of intelligence on the needs of people with mental health challenges and what's required to be done to improve those services. So looking beyond just a contractual relationship and understanding they're a critical part of an ecosystem that keeps people with mental health challenges and their families and carers well and safe.
Thanks, Duncan. We've got another bit of a slightly different aspect. Do you have experience of people being labelled as non-compliant and discharged from community services? For example, because an autistic person couldn't respond to random and intermittent contact offered by services. And in terms of that, how might a personalised care and support plan help in that situation? As you can see, you're nodding away there.
So I just think that for me, throughout all of the work that I've done around personalised care and support planning, the fundamental thing that personalised care and support planning can identify is the needs of the individual, particularly around communication, particularly around interaction, behaviours. Often when you find yourself in a service where people don't understand your needs, you will be slowed up, and potentially that will have a really dire impact on the care and support that you'll receive. It can mean a particular course of treatment, it may mean a particular diagnosis, it may mean a particular intervention, such as if you have a communication barrier or challenge, you're more likely to end up in acute services, where you are then going to be further challenged because actually those acute services won't be able to meet your needs, and where you'll end up here in where I live is probably in a PQ unit. So it's really understanding what's important to people, how they are able to communicate, what interventions that you need to offer, and really planning. And I think things often change, and when people move around the system, and these big, so COVID is a really good example of those people that had contact with people that really understood their communication barriers for many years. Those people disappeared. What happens? The world is full of those people now because nobody understands what they need to do. Nobody understands the nuance of when someone's presenting.
Thanks, Isaac. Rachel.
Thanks, Martin. Not exactly that experience, but a similar experience of people we've supported for many years, living lives with meaning and purpose, and maintaining their wellness in the community, experiencing having their care packages either reduced or removed entirely. So you know, there's one person that we support who had a care package that worked out at about 18 hours a week and was assessed as not needing that anymore because they'd been in the supported living scheme that they'd lived in for 20 years, and the considered opinion of the assessor was that that person wasn't engaging in some of the work that we were doing. And actually what we did, it goes back to Marsha's earlier point, it was about that person's rights and their rights in the Care Act. And actually this person has the right for a life that's well lived and stays safe in their community. And if we remove all of that, we might need the 18 hours a week that they have, but they still need some connection to their support worker. If we remove it all, we will be in acute services in 3 months' time. We can write the script for you now. So yeah, I know it's pressures on systems, but it's a false economy. Because all you're doing is storing up trouble for the future. So that's the kind of experiences we have. That's when we work with our advocacy services, because as a provider we can't do that, but our advocacy services can. So yeah, we just know your rights, really. That's what I would say.
Yeah, thanks. Anybody else on that subject or other? Going to come to the last question in a second. In fact, we'll go there now. The last question for each of the panel: what one thing would you seek to retain from your experience from living through this pandemic? And we'll go with Marsha. Marsha, would you like to say?
One thing is the power of co-production. On a Thursday afternoon, we have an NCAG wellbeing meeting. Isaac and I have been like passing ships along the night a lot of the time, but we also have the same thing and trying to make sure that mental health is at the heart of social care. My worry is that it's not. It's never has been before, but now it's going to be even further down. And we need to really do something about it. That's
okay.
yeah.
Thanks, Marsha. Maybe we'll just mention opportunities around that going forward at the end. Rachel, what one thing would you like to, would you seek to retain from your experience?
For me, the focus on social care. So a better understanding. Most people don't really know what social care is. We all know what the NHS is and what health is, but the focus and the emphasis on social care, because social care is beyond a service. It is about lives lived with meaning and purpose.
Thanks, Rachel. Duncan.
Yes, I'm going to say one thing, but it'll sound like two. So you haven't heard me. There's one thing. So to follow on from Marsha and Rachel there, I think if we can continue to, we have made some progress in highlighting the critical role of, with the support of, you know, TLAP, colleagues at Association of Directors of Adult Social Services, National Co-Production Advisory Group, in highlighting why and how social care has been critical in keeping with people with mental health challenges and their families and carers safe and well during COVID. I think that we need to build on that and understand that social care is perhaps best placed to advance a rights-based approach to mental health and support services beyond advocacy. So my right to a care plan, my right to an advocate, my right to a support, and sort of build an argument and some expectations of services on that basis. And I guess on a personal level, what I intend to build on and hold on to is actually the value of working, you know, with colleagues like Isaac, who I worked with previously, and connecting with Marsha and connecting with colleagues through the association to understand what is possible sort of prosaic here, but you know, hope in the current time is really, really important that we hold on to that. So if we can energize ourselves through positive discussions and making the right connections, then I think that's something we need to hold on to.
Thanks, Isaac.
So my thing that I would like to hold on more than anything would be the co-production. So within COVID, we have really demonstrated that we can co-produce in all sorts of ways. I really do believe that the task force, particularly around mental health, really did have a co-produced approach and had the voice of people. And I think that we are potentially pushing an open door. So for many, many years, mental health and social care felt like the poor relation of health. And I think that we now are trying, and hopefully we'll get to having some parity of esteem, and particularly around mental health. And for that to be really rooted in the experiences of people with mental health challenges and long-term mental health challenges.
Thanks very much, Isaac. So we're pretty much there. It's nearly 5 to 12. Thank you ever so much, panel, for very interesting presentations and sharing of experience that we've had this morning. I think, Duncan, we probably take away from today, there's been clearly significant interest in this subject, and as you said earlier, potentially other subjects we could look at future webinars for together. So in the follow-up, we'll probably be asking questions about what subjects would you like to hear more about, and have opportunities to ask questions. So thank you very much. Please do help us understand what we could do better with webinars like this in the evaluation. And it just remains to say goodbye. Would you like to say goodbye, panel?
I'd like to say goodbye, and thanks to you, Martin, for brilliant facilitation and leadership. And just one final note, if anyone has got the opportunity to put this in the chat, the report of the Task Force on Mental Health and Wellbeing is on the Department of Health and Social Care website. The 12 recommendations, as Isaac alluded to, are really important because the themes of personalisation and the need to address inequalities in mental health services in relation to social care run through that report. So thanks ever so much, Martin.
Thanks. Bye.